Hello, everybody, and welcome. We're very excited to have Neil and Royal from Pair Team here with us today. I thought a good place for us to start would maybe to get both an intro from each of you and then also a little bit about the company before the acquisition, like what your company was up to, and then we'll kind of talk about that. But Neil, let's start with you. Could you give us a quick intro and a quick intro of Pair Team?
Yeah, of course, Martin. Thanks so much for having me again. So Neil Batlivala, founder and CEO of Pair Team. I was a first generation immigrant. A lot of my why comes from growing up abroad in India. And what Pair Team is I'll say, have been on a mission to bring access to high quality care to everyone. And Pair Team is an AI powered care delivery system for the safety net. So we are a full stack medical group that partners with local shelters, food pantries, and other community-based organizations to care for some of the highest need Medicaid and soon Medicare beneficiaries in the country. Folks experiencing homelessness, severe mental illness, substance use, polychronic, high ED utilization. And along the way, we've built out a pretty robust work system to help connect our healthcare infrastructure and public assistance infrastructure together. Um, lucky to be doing this work, and thank you for having us again.
Great. And Royal, over to you.
Yeah, Martin, thanks for having me. Royal Hill, founder and CEO of Town Square. Just a little background in general before we jump in. I've spent my whole career in healthcare. Started actually on the nonprofit side, sort of fell in love with public health and health policy. Um, did consulting for a while, Aetna for a little while, and then co-founded and was CEO of a company called Docent Health, which we ran for about 8 years. That was providing patient navigation services, tech-enabled patient navigation services to large hospital systems, um, like Common Spirit, Northwell, Sutter. And so we ran that company for about 8 years. Maternal health equity was the largest service line that we supported. So we spent a lot of time helping to support patients in navigating social needs. That company was acquired by Get Well Network. Spent a couple of years there helping them scale the asset. And then saw a need in the market to start a new company called Town Square. And the focus for us when we started Town Square was really helping nonprofits and CBOs to get into value-based care contracts, specifically with Medicare Advantage and ACOs. So our focus was creating technology and services to help enable direct contracting between entities that were taking risk on older adults and the organizations that had the capacity and the knowledge on the ground to help provide those services and build technology that would allow us to help improve the coordination of services, but also dollars coming to the safety net for those organizations. Have been really excited to build Town Square and super excited to be a part of the go forward strategy with Pair Team.
Awesome. Before we get into talking a little bit about the strategy and the capabilities and how they're coming together, I'd love to hear about how you two first got connected.
That's a good
Yeah.
question. Yeah, Neil, I think I reached out. We had been very aware of what Neil and the team were doing in California. And there were a lot of similarities and just in terms of like mission and approach and a focus on community health workers, which was a central part of our model. So very much had been aware of what Pear Team was doing, particularly in the ECM space in California. So I think we reached out just to see if there were opportunities for a strategic partnership and collaboration and maybe sort of channel distribution partnerships. And then the conversations accelerated really quickly to wow, this seems like a really nice strategic fit. And Neil started to talk about their strategy for expanding into Medicare and how they were thinking about partnerships with CBOs. And yeah, it was really clearly just a one of those scenarios where 1+1 = 3. And so yeah, conversations converted pretty quickly.
Yeah, it was not on my 2025 bingo card to look towards any sort of an acquisition or anything like that. And then Roy and I started talking, and it was just so clear. It was so clear how when Roy was talking about his roadmap and the roadmap at Town Square, and I was talking about our roadmap at Pair Team, particularly with things like, doubling down at Pair Team, doubling down on Medicare in 2026, as well as just the general philosophy of how you enable community-based organizations to be a first-class participant in our healthcare delivery system, right? Not an informal partner that you refer to, but actual someone that can, drive value and funding directly from the healthcare system. Royal's been one of the only people that I think has been meaningfully thinking about this in a way that, at a level that I was just so blown away by. And it felt very much like two puzzle pieces coming together. And yeah, that was it was whatever is the stars aligned for Royal sending out that first email. I'm grateful for.
It's sort of funny because Nate, the chief medical and strategy officer for Pear Team, and I did a podcast interview a couple of weeks back. And one of the things I was like, well, like, when are you guys going to start working with like Medicare? And obviously he didn't tip his hand there. But then like, I published it this week, and then a couple of days later, this news comes out. So it was very good timing. And I feel like it's also good timing. I was chatting with someone about ACOs yesterday, and they were talking to me about how about 40% of Medicare beneficiaries have health-related social needs. So I think I am getting a good picture for the strategic rationale, but talk to me a little bit about, in terms of geographies, capabilities, markets, and payer types, like what's the combined entity going to look like?
Well, I can take a swing at this. I will say, so we're largely concentrated in California and expanding out beyond that now. Town Square had built largely a technology, software infrastructure. So it's scalable and deployable anywhere you want to go. We have obviously a pretty large group in California, so we're going to be focusing out there first. And then, other big states with Medicare populations, right? You have, you just look at it by population size. You've got Texas, New York, and Florida, right? Are the easy contenders out there. And so geography was less of a concern in all of it. I think what was the biggest for me was the sheer amount of thoughts and care that had been going into both the technology strategy at Town Square as well as the go-to-market strategy at Town Square. So Royal and team had been thinking about all the different models to work in both traditional Medicare, managed care, with ACOs, et cetera, that we can ultimately leverage, across the country here.
And Mart, I think you brought up a really good point that I think had been overlooked. A lot of times we talk about unmet social needs, and it's an immediate assumption that you're focused on Medicaid. The older adult population is really struggling today. Like economically, they've been compressed coming out of the pandemic. You have more seniors with chronic diseases. You have more seniors with unmet social needs. Transportation, social isolation gets some headlines, but it's really a population that has a lot of upstream drivers of clinical risk. And it's not that we didn't know that, but I think what is changing is that the unit economics are now allowing us to scale these types of programs that Pear Team has built, leveraging AI tools to actually deploy in the economic models and having economic incentives that allow us to do this at scale. And so that's, I think, what's really exciting as we look at these two models coming together is just leveraging the clinical expertise as well as the AI backbone to scale these types of programs to that kind of like mid-risk and rising risk cohort that just sort of economically weren't viable to go after previously.
And maybe you two could walk us through, I guess, like an example of how the platform is going to interact with the Pear Team, the medical group, and as you're thinking about going into a Medicare, like, can you give us a toy example or something that something we can kind of better grasp how exactly it's going to work?
Yeah. Like Roy was saying, we've kind of been building an agentic care system for a while now. And it's a system that spans across pretty much all stakeholders in the safety net, both medical and non-medical organizations. So take someone who walks into a either primary care office or gets discharged from a hospital, or even walks into a local community health center like uh, uh, the area agencies of aging are big central backbones in communities. And you walk in and you have a agentic support to help make sure and navigate your social care needs, whether that's helping you get access to public benefits that you're eligible for. I think the statistic out right now is about 30% of benefits that folks are eligible for are not being used appropriately, right? So just being able to get screened, help you run through the application process for all of that. But then this system, this, personal AI health assistance or navigator is also backed by an entire clinical team. So not only can you address their social needs in the moment, and again, do this in a very high touch way, right? We're talking about check-ins on a daily basis, right? Very personalized, but then also back it up with clinical care management, right? The controlling of your diabetes, your hypertension, et cetera. And if you look towards what the federal government is doing right now and things coming down from Dr. Oz and CMS, they are incredibly bullish on how do you provide, massively scalable chronic care management across the country. They just launched a program called Access, which we have kind of full intention in being a participant of and bringing this access program to the safety net. It allows for traditional Medicare beneficiaries to, tongue in cheek, you'll get access to a lot of the services that we provide because they're technology led, AI led in that way. And so you can imagine basically anyone who walks in the door to any of these organizations can be connected to our social care services or medical care services agentically.
One of the things that strikes me, in hearing you talk, Royal, and talking to Neil before, is the community organizations that you guys are partnering with are incredibly resource constrained, and there's just not been a lot of infrastructure historically to help make the connection between the social need, the health need, and actually a doctor or someone who's taking risk being able to make those connections. So I'm curious, practically, what does that network build look like? Are you just like knocking on doors of every homeless shelter and food bank, or yeah, what does that look like?
Yeah. Maybe you want to start with the Pair Impact Network and sort of how you've built the network you have today, which is pretty impressive across the state of California, and can share a little bit more about how we're thinking about it on a national basis.
Yeah. What's funny is Royal and I both came at it with the same way, which is funding and tooling and all of it, right? We're the only ones going to these organizations and saying, hey, we'll help you participate and get access to healthcare dollars. And here's tooling to support you in doing that. So we were doing it as, quote unquote, value-based activities that community-based organizations can provide that help align to our medical group and the care management contracts that we are a part of. And what we've seen is just a lot of appetite from local organizations to, one, get access to sustainable revenue streams, but also do more for their community, right? What drives these organizations and ultimately drives us too is that we want to be able to provide more services to the clients walking through the door, right? And if you can be a trusted medical partner to some of these organizations, right, that suddenly opens up so much more that you can do with them. And it has this very virtuous cycle where it's all about capacity development. It's saying if you can get more dollars down into the hands of the community, they can reinvest those dollars into themselves, grow and scale. I remember one of our first shelter partners actually launched a second shelter site because of the dollars that we were able to bring down to them, right? And that's exactly the sort of like sustainable virtual cycle that you want to drive with all of it. One of the quick corollaries is you're able to do more long-term planning also when you have these sustainable revenue streams. When it grants are usually 12, 18 or so months. And then you realize that, oh, that money is going to stop coming in. What do I do? next, well, you got to go chase the next grant. And so we can provide really consistent, high quality funding to these partners.
Yeah, and I would just add on to that. I even take it one step further. I think a lot of the community partners and leaders that I've talked about are frustrated. Like they feel like a lot of their referrals are sort of getting thrown over at them, and because they're a nonprofit and it's in their mission, they're just, expected to take them, and they've sort of been treated as a downstream product, and they haven't been brought to the table as a partner. And I think there's a real desire for organizations to be a more sort of integrated partner, um, and to Neil's point, it's, hey, if you can like just giving us a better understanding of what the volume is going to be coming in, and if we can develop partnerships that are value added and brings revenue, then we can scale up our capacity. And for them, that's so important when they are operating on thin margins, and they have a lot of requirements across grants and everything else. So I think a lot of this is just helping to sort of bring them to the table as partners, and have a conversation around mutual ways to create value. And sometimes that's, technology, and sometimes that's contracting, and sometimes that's just having open channels of conversation, and being able to plan together.
One of the things I remember, I was reading Rough Sleepers, the Jim O'Connell Healthcare for the Homeless in Boston, and they talk about this thing that they basically had to do every night, which is call every shelter that they knew and ask them if there were any beds available for a specific one of their patients. I'm curious what the current state of like technology and with the CDOs that you're working with is, and what your sort of like what's the interface look like today. There's not, I don't think, like an API that you can just ping saying uh are there any beds available.
No, unfortunately. I mean, this is one of the things behind unifying our healthcare and public assistance infrastructure in the country. So we've actually done quite a few things with responding to like RFIs by Health and Human Services or CMS around interoperability here. Being able to actually, incorporate, as part of TEFCA, for example, actually have community-based organizations be a provider type that participate as part of this national directory. And in the same way that providers can provide things like, appointment availability, they should be able to also provide, a shared infrastructure for resource availability. This is and you can create a national standard on it. There's been a lot of work that's going towards it. We're trying to contribute to that, the bolus of work. What happens now, I'll give you maybe a simpler example, which is for homeless organizations. You have the homeless management information system. So it's called HMIS. It is usually state specific, and it's a way for basically bed availability to be tracked. So it is a system that is used statewide that, should be tracking beds and how they're used. Every day, a shelter organization or a housing organization will have to fill that out, and they have to do it for compliance reasons. The challenge is that no one really has access to that information. There is really one queue that gets pulled from here, and all this technology was built maybe 20 years ago or so. These queues get filled up from screening assessments that get done, but those screening assessments become stale. And so, if the queue of who needs a bed is meant to be as real time as possible to actually drive the best, be the most effective in terms of who gets a bed for that night, it's not there. All right. It gets stale. People get on that queue and they have no idea where they are in that queue, and ultimately becomes a very closed system. And one of the things I'd love to see is that become more interoperable with just the rest of healthcare infrastructure. This is one example across pretty much every type of basic need out there. The systems do exist, just is the data actually accurate and refreshed on a consistent basis? And without that, you can't make high quality decisions in the moment for somebody, right? Like what I like to say is patients have a need in the moment, right? It's tonight, right? It's that day. I can't wait 2 weeks. And that those are the sorts of things that if we can create better interoperability and have agents on top of it that can respond to it in real time, that's when you start to be able to drive real outcomes and put people on an upward life trajectory.
We have about 5 minutes left. And so I think at this last question, just want to kind of hear your thoughts going into 2026 and beyond, what you're excited about. And then as a subpart to that question, you think Medicaid, which has historically been your focus, Neil, you think Medicare, are you thinking about dual eligibles? Are you thinking about PACE? Like what does the trajectory look like for 2026 and beyond?
Roy, I think you're driving a lot of the Medicare work right now. If you want to share
Yeah,
it.
yeah, happy to jump in and you can keep me honest. Yeah, it's an exciting time for us. Pair Team as a medical group has the ability to expand their offering into fee-for-service Medicare. And so that's going to be continue to be part of our partnership strategy is expanding fee-for-service Medicare programs, and able to do that with increasing efficiency as well. We are, as Neil mentioned, really bullish on the new access program that's coming up. The rates haven't been released yet. They will be low. I think they will be very low.
Disciplined
Yeah,
is
disciplined, I guess is the right way to say it. But I mean, like, but strategically so to incentivize, agentic models and innovation in this space. So it's not meant to, or is it going to be um, um, sustainable for organizations to enter into the access model that have very high labor costs? That's not the intention of the incentive. So for us, we're really bullish on the opportunity to leverage the access program to improve the ability for patients to get connected to care management services or social navigation services, and partner with organizations, whether that's ACOs or health plans or community organizations where we can provide that sort of wraparound service to their members and their patients. So I think those are the two big tracks for us as we look at 2026.
I'll maybe one thing very like you said. I think the bones that Access puts down are right. Things like patient choice, things like outcomes based pricing, things like moving us away from actuarially driven revenue and not having to be an actuarial battle with plans. We want to try to take some of those bones and bring it into managed care as well. So talking
Yep.
to state leaders and managed care leaders to ultimately accelerate, safe and responsible AI adoption. And we think care management is the right starting point.
Well, this was great. Thank you both so much for your time. Any sort of parting words for the HTN community? Otherwise, we can leave it there.
I got one, which is we are so lucky to have Royal on the team, leading our networks here. And I just want to say we are hiring across the board, particularly we are looking for a finance leader right now, a finance leader who can help drive our AI investment strategy, help look, both lead the finance department internally, but also be external with me on securing capital to grow our agentic work system across the safety net. And then we're also looking for product leadership. So product leaders who can come in and lead different parts of our platform. We have a ton of surface area. And if you think about the future of AI and what it looks like to bundle and help, expose capabilities to just do more good in this world, we think we have the right, ultimately proving grounds to build out some really powerful agentic tooling for the world. So if you are interested and aligned with our mission, please do reach out.
And if you shoot me those, I will make sure they end up in the HTN Slack if they're not there already. Thank you both so much for your time today. Enjoy the rest of your Friday. Stay warm, and we'll talk soon. Bye.
Thanks, Mark.
Thanks so much, Mark.